can let me know if there's an issue with that for anybody. So hello and welcome. This is an informal learn and share hosted by ourselves at the Cheshire Merseyside Cancer Alliance. We're just wanted to share the Improving Molecular Pathways and Cancer Turnaround Times project, the IMPACTT project, and some of the work we've been doing here in the Northwest. Next slide, please, Anna. Just going to dual task and let people in. Hi everyone, I'm Steve Jones, one of the senior program managers at the Cheshire Merseyside Cancer Alliance, and I oversee genomics for the Alliance. So we've got several speakers today. We're going to try and get through everything as quickly as we can and leave chance for a Q&A at the end. We'll just quickly go through sort of the shared objectives and the purpose of the IMPACTT project, what we try to achieve with it, the strategic overview and regionally, and then we'll go through the actual project itself. We'll take a look at some of the data tools and then a quick summary from pathology and clinical perspective. And like I said, there'll be a Q&A at the end. So if you can leave questions for the end, we'll be monitoring the chat though. So if you want to use the chat, by all means do. Next slide, please, Anna. Thank you. We put a bid in with the Northwest GMSA in late 22, early 23. And the project was born out of a lot of information that we were receiving, although it was all anecdotal, that there's significant variance across a number of our pathways. And what we understood was that in order to get to the bottom of this, that we needed to do some very detailed baselining. And we'll go through that. My project manager will go through that later. But we also recognise that this would be working in the unknown. So it's a new space for cancer alliances. It's not something that we would routinely or be mandated to work in. And so you'll hear a lot of the learnings that have happened throughout, and there's been a lot, but on the whole, largely positive. And the aim of the presentation today is that we really wanted to share best practice of how we might go about a piece of work like this for our regions. We think it's incredibly valuable, and hopefully people do too. The ultimate aim for this was to try and speed up turnaround times for the molecular component of some of our cancer pathways. And the best way to do that is to work in partnership with all of our system stakeholders, obviously directly with the labs, and to try and share best practice and to try and remove some of those barriers. So next slide, please, Anna. So I'm going to hand over to Stuart Bayliss from our Northwest GMSA. Thanks, Stuart.
Thanks very much, Steve. Hello, everybody. Next slide, please, if I could. So Stuart Bayliss, Programme Director for the GMSA Alliance, and just set a bit of context for this project, really. We came out of a few discussions we had on this. Was relatively early days, sort of a year or so, 18 months into the sort of existence of the GMSA, is how we start to bring together sort of network working. And just really the context for this was the regional complexity. That picture on the left there is, the Northwest region, 3 ICBs, 25 acutes, over 1,000 GPs, 2 specialist cancer trusts, now 3 cellular pathology genome centres, and 7.5 million population. Think about that in that context of how do we begin to look at genomics and approach cancer. Sort of had to scratching our heads a little bit and thinking how should we go about this, and then conversations with Steve and colleagues at the other cancer alliances sort of started the genesis of the IMPACTT project. So if we could go on to the next slide, please. Thank you. So for us, it was very much as a new kids on the block, really, is how do we begin to work with our partners across the system, the clinical teams, the cancer alliances, the pathology networks, workforce development teams, and ultimately how do we begin to improve the outcomes for the health outcomes for patients in the Northwest. So really thinking, let's line this up with national priorities. Cancer's a a good fit. We know from working with colleagues in the GLH that there are issues across pathways. But as Steve was saying, how do we build evidence for that? What do we tackle? Where do we go with things? And how do we begin to build those relationships to have a functional network in the Northwest that allows us to really tackle these problems on a sustainable footing rather than the usual sticking plasters? So sort of IMPACTT was born, and very well led by Steve and the teams at GM Cancer and South Cumbria as well. Cancer Alliance is there. And really, as Steve was saying, our idea was to get together a baseline. How do we baseline where the challenges are? How do we then share best practice where those challenges have been overcome? And how do we do that across 3 ICBs, different providers, different pathology centres, all working in slightly different ways, where you can't just lift and shift between centres. So that was really the sort of the thinking behind IMPACTT. And to also think about the future is, where are we going with genomics? How do we begin to change at the system level to accommodate genomics and make that fully embedded within pathways? And if we just move on to my final slide, please. Thank you very much. Just part of the future is we've been commissioned, as all the GMSAs in England, to deliver a cancer genomic improvement programme. So really, I think IMPACTT really showing us the value of why we should be doing this, and these are deliverables. I won't run through them all or in any detail, but I think the future being, I think, a very holistic, or trying to get a holistic approach to improvement in cancer, and certainly from our perspective, the genomics part, but really seeing that as part of an end-to-end pathway where we can, and very much focused on what benefits the patient within that. So that's the context and sort of this more strategic sort of regional genomic overview. I think that's my last slide. So I'll go back to Steve, but join the Q&A later. Thank you.
Thank you, Stuart. So we're going to hear now from Grace Berry, our project manager. This is pre-recorded as she's currently enjoying maternity leave. So Anna, if you could press play on the presentation, please.
So hi everyone, I'm Grace Berry. I'm the Genomics Project Manager for Cheshire and Merseyside Cancer Alliance, and I'm just going to talk you through our approach to the IMPACTT project, some of the findings, next steps, and some of the lessons learned as well. So IMPACTT stands for Improving Molecular Pathways and Cancer Turnaround Times. And we've been working across the Northwest for the last year and a half or so in partnership with the Northwest GMSA, the Genomic Lab Hub, and the 3 Cancer Alliances as well, with the aims really of supporting improvement work, mitigating any variance across the patch, and ultimately looking to reduce turnaround times within genomics pathways for patients. So each Cancer Alliance has chosen their own priority tumour groups, and that was based on the understood need or complexity of each of the pathways. In Cheshire and Merseyside, then we focused on gynae, which was just for ovarian and endometrial cancers, colorectal and breast cancers as well. We did collect data on teenage young adult patients, but it was a bit too much of a bigger beast to take on at the moment. So we've got the data on that, and hopefully that'll be used in future work as well. And I split the approach into 3 stages, so I'll go through each of these in turn. We've got pathway mapping, auditing work, and then just essentially collating a list of issues and actions throughout each of the system stakeholder encounters, really. So a little bit about the approach. I first went about introducing the project to all relevant stakeholders to gain their endorsement and to have a clinical lead contact for each tumour group that we were looking at. Other than the individual meetings with those clinical leads, I presented the plan to each of our relevant regional CQGs, so the clinical quality groups, and we have one of these groups for each tumour type. And from those meetings, I was able to actually gain more contacts and agree a plan for me to go and shadow some of the local MDTs face to face at each trust. really to get an idea of any problems that were faced, and for my understanding, to understand how these meetings work. And the face-to-face meetings with the CNS has actually proved really, really valuable in my understanding and documenting any issues. So that was really beneficial. I presented to the pathology network, which is made up of the cellular pathology managers across the region, again to share the project, its aims, and actually the requirement for them to help us with this audit piece of work to be done by their teams. Because it was really evident that there were, and actually still are, significant capacity issues facing all of our pathology labs. Some are worse than others, and because the data that we needed to collect was only really going to be possible by kind of hefty manual collection across several systems, in the end the Cancer Alliance offered to provide a small amount of funding to each laboratory to pay for overtime for the data collection. Hopefully in future there'll be a bit more of an automated way to capture this information, but we're a little bit of a way off that. So the funding actually worked really, really well because we were able to get data from across all sites. And then I attended all 6 of the path labs to have a tour of the lab and a walkthrough of the sample pathway, really, from when the sample enters the lab through all of the processes that it goes through. So that was really the start of the pathway mapping to document the processes and the decision trees, and I'll go through that. I'll go through that now. So I mapped each pathway from point of biopsy right through to when or how the results are received in clinic. And by doing this for every pathology site across Cheshire and Merseyside for each tumour group, we were able to easily visualise the variance across pathways and processes, really, and identify improvements as we went. So you don't need to look at the detail of this pathway map. I just wanted to exemplify really where we noted some obvious variance across the region, and I've had to split the pathway map across 2 pages for you to be able to see it. So I hope you can get the idea from that. So from the top then, some sites had additional logistical issues to get around. Inevitably, some labs sit outside the region that the trust is based in. So you've then immediately got added transit times as well. There's potentially some work we could do on a logistical mapping pathway in future, but that was interesting to note the effect that had. One site didn't have the immunohistochemistry staining method validated internally. So after the diagnostic report was completed, those samples then had to be outsourced just for the IHC staining before being sent back to the trust for interpretation and reporting. Clearly you're adding time there to the patient pathway. That has since been resolved. Reflex testing, so that's automatic testing in a given scenario, and that's mandated for certain tests to speed up the pathway. Some sites were doing this, other sites were not, and instead that they were waiting for the specialist MDT discussion to get the green light for testing. Again, adding days probably onto the pathway. So we've done a little bit of education work as I've gone around the MDTs, and that is no longer an issue. Yeah. And then one site was also sending their slides to the GLH via second class post rather than first class or recorded delivery. Again, an easy one to pick up. I suppose it's easy to be overlooked, isn't it, really, if it's just that's kind of the trust rules. So we've worked with that trust to make some changes so that they're not losing valuable time just in the postal system. And these are just the small incremental improvements that were picked up through the mapping work. We've already been able to have a really positive impact on the turnaround times before we've even got onto the auditing of the pathways, which was a significantly bigger chunk of the work. So I hope that just gives you some of the examples of the obvious variance that we discovered. These are just a few of the examples of the issues or the barriers that were reported across the pathways. I split them into audiences to make them a little bit more digestible. So we've got pathology, clinical teams, and system-wide. Clearly, it's not an exhaustive list. I just wanted to pull out a few examples. But actually, in the interest of time, I'm not going to go through these points. I've touched on some of them earlier, and I'm happy to share these slides afterwards as well. So the audit template then, I sent out an audit template to all the pathology labs, and this is really just to show the vast amount of data fields that we collected with the column titles listed. It was a little bit tricky to get them onto one page, so I hope you can see that okay. The template was adapted a little bit from the one that that was used in the GPAT project, so the Genomic Pathology Accelerator project, I think it stands for. That was a national project, mainly because it covered a vast amount of data fields in the pathway, and we didn't want to recreate the wheel and waste time. It would have been a lot more difficult to have started from scratch to create this audit template without, you know, significantly more input from the experts in pathology as well. So as you can see, the audit logged lots of quantitative data from the sample, every sample collection and the sample transit through the cellular pathology processes in the lab, each step in the immunohistochemistry processes, the genomic testing pathway processes, all up until when and how the report is delivered to the clinical teams. And as well as that, we were able to include some qualitative data for each entry as well. So that described the type of test that was requested, how the samples were sent to the GLH, which staff group was routinely undertaking each process, so we could look a little bit more about the workforce groups as well. So that was really, really useful. So in total, we received data relating to 473 samples across the 4 pathways, and you can see the split there. We asked for about 20 to 30 cases from each tumour group from the labs. And as I mentioned, this data can only really be pulled manually through navigating several systems, and it was really, really time intensive to do so. So the funding we provided for overtime was really beneficial in helping us get a full data set across the region. This was just one example really to show the variation in turnaround times in pathways across Cheshire and Merseyside. But actually I think Jenny Hampson, who is our data guru and pulled together all of this, all of these visualizations for us, she's going to talk a little bit later on, so I'm just going to skip over this slide in the interest of time. And then I've produced lab-specific evaluation reports for each of our 6 pathology labs across Cheshire and Merseyside. And those reports contain tumour group process maps for each of the tumour groups we looked at, the regional audit data, and then digging down into the lab-specific audit data, as well as some recommendations for pathway improvements, some of which you can see on the right-hand side there. So similarly to earlier, I split them up into audiences of pathology, clinical and system-wide improvements. Some of the examples are around the specifics of testing for each pathway and potentially bringing more testing up front in certain cases. Some of the non-kind of technical examples were around standardising the way the tests are requested across the region, ensuring sufficient information is included, as well as working to provide genomic education to the workforce in an appropriate way as well. Because the majority of test requests come from oncologists at specialist centres like Clatterbridge at the minute. But as the tests become more and more mainstreamed, there will be a need to push that back into district general trusts. So there's definitely a level of upskilling required. Now these documents that I produced are quite lengthy. They're about 50 pages or so, with all the detail in there. So I've condensed the higher level information and recommendations now into one document, just to take forward for the region, really to start to embed those positive changes to reduce turnaround times. And we plan to appoint a pathology genomics lead for Cheshire and Merseyside in the very near future, to help really support with the embedding of the impact recommendations to reduce those turnaround times. We didn't want these evaluations to be documents just sat on desks for interest. We wanted them to really promote action. So we're hoping to optimise the pathway services and ensure equity of access to genomic testing across the pathology network as well. We'll continue to monitor and measure improvements and potentially extend impact into other tumour groups if resource allows. We know that there's a huge need for genomic education. We've been working with the Northwest GMSA to produce tumour-specific genomic education webinars. We've completed those for colorectal, that went live in April, and I've pre-recorded my section for gynae, so hopefully that'll be due to go live, I think, in October time. And we'll just continue to work through the tumour groups that IMPACT has looked at across the Northwest over the next kind of 12 months or so. And they're available on the Northwest GMSA website, so I've put the link there, as well as our Cancer Academy locally. And they'll be in bite-sized chunks, so I think they're about 15 to 20 minutes per module, so hopefully they'll be more digestible for busy clinicians. And then as a Cancer Alliance, this project has really helped in our understanding of the gaps across the system. So we've developed a genomic strategy for the next few years to focus and align with the Northwest GMSA, Clatterbridge Cancer Centre, the GLH and the pathology network, so that we're all working towards common goals as well. So it's really helped us take off our genomics programme in the Cancer Alliance. Just finally, to come on to some lessons learned, if I've got time, partnership working, it's been really beneficial to have been able to build stronger links with our pathology network and with the other cancer alliances in this region. As our work together grows, we can learn from each other and align future projects and focus as well. Stakeholders, the scale of the work is still massive, as all workforce groups are involved. It was difficult initially to establish where the test requests were coming from and therefore who to include. We know that that's mainly done in oncology, but so far a lot of the work is focused on specifically on pathology pathways to improve those, and we've worked with the district general MDTs. I have engaged with oncology teams at Clatterbridge, but there's definitely more work to be done in connecting all of the work across this region because it's just so vast. The regional versus the trust model then. So it's been difficult looking at 6 pathology labs and many trusts across Cheshire and Merseyside in one go for multiple tumour groups. So potentially working through one trust at a time, looking at all 3 tumour groups may have been more impactful to see change more quickly, rather than trying to tackle the whole region at once across several tumour groups. But actually, having said that, there are 6 pathology trusts across Cheshire and Merseyside, and it's also difficult to enact change without moving as a region. And had we done any differently, actually, it might have created more variation and inequity in finding different issues at different times. So I don't think there's a perfect model for this. But now that we're at the point of appointing a genomics pathology lead post within the network, I really think that that's a positive way forward to embed change across the region equitably through the recommendations. Measuring and monitoring improvements without ongoing automated data collection, it's really difficult to measure and monitor improvements as it relies on the manual data auditing again. So we're going to have to consider how we're going to measure that change moving forwards through the evaluation. I've mentioned the funding worked really, really well, and I don't think we'd have been as successful without the funding for the overtime for the auditing work, because we've been able to get that information across the board despite difficulties with capacity. So that was really useful. And then finally, the audit template improvement. I think in future, the audit template could be improved. The audits were completed differently by different trusts, so there's definitely more work to be done to standardise either the template or potentially simplify it for our purposes. Now we know what we want to get out of it. As I say, we used the template from the GPAT project at the time because our knowledge and resource, I suppose, was more limited. So there's definitely room for improvement on that as well. So with that, I will hand over to Steve for any questions. Thank you very much.
Seamless. So as you look at that, that's a pre-record from Grace. So we're now going to hear from Ellen Whiteside, who's the project manager in the Langston South Cumbria Cancer Alliance, just on some of the next steps that they took on from the work that they've done up there. So Ellen, over to you, please.
Thank you. So I've just got a quick 5 minutes on so we started a year later just due to some recruitment issues, but some of the things that we kind of learned from there going. So next slide, please. So in the first instance, it was really important to align our goals and understand what they found to be the most important. We wanted to create something that was easy to replicate across the region. Make sure we're both going from point of biopsy, splitting issues in the same sense so that we can create an equal kind of improvement plan. Looking at the definitions, because we all have slightly different ways of working. So to get that data in the same format, we needed to understand how we were defining things. And again, good data is equally comparable. We also tried to look at the same things as well. So not just on the audit template, we looked at what we were drawing out of the data as well. So I think that aligning of goals across a region makes for a better piece of work. Next slide, please. So these are some of the things that I did slightly differently, or me and Grace did together, based on her learning and me taking it on. I got a chance to do an MDT survey, which I think helped, and I think that we could have, that was good kind of for the region to engage some of the other partners from across the region in the regional MDT. So we wanted to look at kind of ways of ordering molecular markers, looking at genomic representation in the MDT. So I think this was a very pathology focused piece of work, but it was really good to engage that kind of outside perspective. And I think one of the things that we've learned from this with the implementation of CPGCs in the recent months, we're going to use this as a baseline and continue this piece of work. And I think each of the networks within our region are going to do the same thing. So we've got the implementation of CPGCs at the minute. We've got our baseline, and we're going to use this to audit any measured improvements or changes in certain pathways. Next slide, please. You'll find this is quite similar to Grace's approach. So we standardised the way, especially we were looking at the exemplar pathways and the way that we drew variants out of each kind of step. So some of them will be network specific and some of them will be regional. We did kind of a crossover piece to try and look at some of the maybe educational learning things that needed to be driven out of that. We also looked at kind of transport networks and things, because every network will be different. So it's understanding what's specific to you and what can be addressed in a regional perspective. And then the education pieces and knowledge gaps that came out of it. I'll talk about that a little later, but I think some of these education pieces around different pathways are there's a lot out there, and I think that combining resources and kind of resource pointing was one of the biggest things that we came to draw out of this project. Next slide, please. So I just wanted to give a bit of an example really on kind of showing you how we sorted our data, which Jenny will be talking about in the next presentation. As mentioned, we tried to not only kind of standardize the way that we were defining our data formats, but also looking at the same titles so that we could compare some of the issues that were, again, regional or network. So this is looking at the distribution of time taken from GLH report receipt to report available for oncology. So all the work has been done, and it's just about oncology getting that and making a treatment decision and something meaningful out of it. And it was really interesting. It's something that we hadn't kind of thought that would be an issue. That ended up being a really impactful piece of information. So 2 of the trusts in our network had a large variance of days between this becoming available. When I delved into it, it was because there was 2 pieces of why this was happening. It was an education and a system interoperability issue. They thought maybe the oncology got a copy. The system didn't allow easy integration to people copying and pasting. And with genomic results, that's very it can be notorious, and obviously a dot or a comma can really make a difference in these. So we needed to find a way around this, but already for a cost neutral in a cost neutral way. We've managed to, I think, half this so far, and that was very impactful, and we could sort it straight away. So next slide, please. So this is some of the priorities and work so far. This is a very high level stuff, but we within each trust they've got their own information, but this is kind of a high level development of genomics within our network and as a region. So and I think it's understanding that that access to across each tumour pathway and making sure that that people are informed of these of everything that's out there to help develop best practice. So this is available to look at after, and any questions, let me know. And then next slide, please. So next steps, we decided to filter out into education pathway and then a histopathology improvement plan. Overall, we had to understand that we're looking at genomics as not just a thing on its own, it's integrated with histopathology. So we're doing a larger kind of target of histopathology improvement with genomics integrated into that. We are continuing with the IMPACT project and hopefully going to come out into new tumour pathways, and again hopefully look at doing the similar ones to Cheshire and Merseyside so that we can look at some education pieces and work across the region. We are going to focus on some of the things that's been really good to come out of this is we didn't have a cancer education hub, and that became an obvious piece of work, but because we've done this project, I think we've had a collaboration with Cheshire and Merseyside, and that's been really useful. And again, just as Grace mentioned, those ties and kind of developing those relationships across the network. And that's me. Thank you.
That's great. Thank you, Ellen. So next, we're going to hear from Jenny Hampson, as you've heard mentioned a couple of times, who is one of our BI leads within the Cheshire Merseyside Cancer Alliance. So Jenny, over to you, please.
Hello everyone, I'm Jenny Hampson, as Steve so nicely introduced me. I'm one of the senior analysts with Cheshire and Mersey Cancer Alliance, and I work specifically with Grace on the audit section of the project after she'd done the pathway mapping, and also on the sort of report creation and design. If we could go on to the next slide, please. So as sort of Grace spoke through in great detail and knowing much more about the project than I do myself, we knew that there were 4 sections to the data that we wanted to look at. There was transport from the initial trust to the pathology lab. There was how long samples spent in the pathology lab, how long was spent in the genomics labs, and then how long it took to communicate results to clinicians. Now, as part of our audit, and this is part of the learning, I suppose, that we took away and that Ellen was able to build on in the example that she's just given, where she's talked about communicating results back to clinicians, the data we collected actually stopped at the point where the reports were ready to go back to clinicians. So what you can see in the chart at the bottom of this slide, you have to squint to see it, but I'll tell you that the orange sections of the chart are how long it took to transport the samples to the lab, the first section of the flowchart. The blue section is how long in the pathology lab, and the green section how long in the genomics lab. So as you can see, the genomics portion of the time was the largest and the one that has the most significant impact on turnaround of the pathway. We wanted to present the data in a meaningful way, and if we could just go on to the next slide, please. We had, as Grace mentioned, over 68 data items per row to deal with. Now, we didn't use all of these in the reporting itself, but when we were digging down into the data to look at anomalies and outliers, that was when we used some of the more detailed granular data to understand what the reasons were behind those timeframes. We could purely have collected dates from and to and done similar charts to what you actually see in the report, but we would have lost that richness of data in order to interpret it and actually understand if there was an underlying reason why some tests took longer than others, or if it was data quality issues, or if it was an anomaly, because we will always have those 1 or 2 that are slightly out of kilter with the standard performance for everybody else. We were dealing with 7 pathology labs if we include the TYA data that was collected at Walton Centre, variously going on to 8 different genomics labs, and as was mentioned in Grace's report, about 470 individual rows of data. So it was a lot to look at. And if we could just go on to the next slide. We started off with the simplest option because everybody loves a bar chart. You can see we use scarf charts, which are the ones that run across the page, and bar charts showing minimums and maximums and averages. And I think that's because for all that we want to be innovative and have exciting visuals, we also know that we want people to be easily able to interpret the data. And going with a bar chart, it's something that's familiar to people and very readily able to interpret that data quite quickly. So I'm always keen to keep things as simple as possible if we can. But what you look at with this sort of chart is you're looking at averages and you don't see that richness of data that we knew we'd collected. So what we actually then did was we took some learning from another project that we'd worked on to do with rehabilitation and applied that to this project. And if we could go on to the next slide, please. Thank you. You'll see that these are the charts that you've actually already seen in some of your presentations previously, but these bubble charts allow us to look at the data in a much richer format while still keeping it relatively simple. You can see that in the left-hand chart, each cancer type has a different colour. The size of the bubbles indicates the number of samples that we're looking at for any given point, and the place on the upwards axis is how long that took. So you can see the range of times, and you can see where the most common turnaround times were as well. And I think that allows you to quickly see if there are any outliers, any that you want to go back to within the source data, which is what we did. And we were able to look, for example, at the gynae outlier there that sits at around about 43 days. We would have been able to go back and look at that particular case and see if there was anything about it that we could identify without going back to the labs to understand why that might have taken longer. Be it that it was a specific test that was different to the norm, had it come across Christmas and bank holidays, particularly for the transportation initially from trusts to the pathology labs. We did see that on average it would take 0 days if you count it as going and arriving on the same day. However, we did have outliers, and they were very generally sitting across Christmas or Easter. Or there was this audit ran across the period where we had 1 million bank holidays in the year because we had coronations and all sorts of things that I lost track of. And we were able to see that in the data and understand by looking at the days of the week as well as the dates exactly why that might be taking longer, which was really helpful and helped pick up on some of the improvements that I think have gone back to trusts as recommendations. We looked both at the tumour types. We also broke it down by the GLH labs, as you can see on the second slide as well. I think I have another slide if we go on to the next one. Yes. We wanted to take this learning and report it back to the pathology labs in a meaningful way. And as Grace mentioned in much more detail in her presentation, we produced a report for each of the participating pathology labs to go back to them. So each of the labs had the same charts that you've just seen on the previous page going into them. They were a fairly standard layout, but what we did was we personalised each of those reports to reflect on the data from those labs. So although you would see the same chart within each report, the actual data that was talked about in the text would relate to the range of days for the cases from, say, WOOF, from Wirral University Hospital Trust, as opposed to the range of cases across the whole of Cheshire and Merseyside, because we wanted it to be helpful to that trust. We wanted them to understand what we'd found from their data. And I think that was really important, that because we didn't make individual graphs for each trust, we were able to turn it around in a much quicker time. It wasn't too onerous a task, because you would have been looking at tens of hours at least, going into potentially the hundreds, to have produced individual charts for each trust, for each of the graphs that we had. But by doing that data analysis on a trust basis, on a pathology lab basis, I should say, we were able to give that specifically useful data. And I think that's really important, so they don't feel like they're just having a generic response to having done all of that work, because the investment of hours to produce that data was significant. And Grace mentioned that there was some funding provided to do that. But even so, I think that it's important that the labs feel that their time was worth it in terms of the information they get back. So that's my presentation, not really talking about the actual outcomes, but more about the path we went through to produce those reports and why we felt it was valuable for that. And we then shared with Lancaster and South Cumbria sort of our learning from that, so that they were able to hopefully take that on in their reporting as well. And that's it for me, I think.
Fantastic, Jenny, thank you. And thanks again, because I know it was a phenomenal amount of work. Next slide, please, Anna. So unfortunately, James Wingfield, who's a director and manager of clinical labs, isn't able to join us. So I won't pretend that I will be in a position to interpret what he's written here. So I'll leave it up for a moment for clinics just to have a read through. In general, I think, and James has been very closely involved in IMPACT across the entirety of the lifespan of the work. And I think it's been really important to have senior and very wise and very experienced involvement in this from our local labs. It's something that is obviously and clearly very technical and very complicated, but it's also something that the system as a whole has found really valuable. So having somebody to help us interpret some of the stuff that we've been learning throughout the work has been incredibly valuable and has helped lead us to recruit a genomics pathology lead. So I'll move on from this slide. Hopefully you've all had a chance to have a quick look. Like I said, it's being recorded and we'll host it on our Cancer Academy website if people want to review it again. Next slide, please, Anna. And lastly, but by no means least, we're going to hear from Dr. Rosie Lord, who is our clinical lead and Deputy Medical Director at the Clatterbridge. So Rosie, over to you.
Thank you. Yes, thanks for the introduction, Steve. And I would just like to thank all the alliances and Stuart at the and others at the GMSA for the immense work that's gone into making this project and getting the kind of data we're seeing today. So it's been a phenomenal piece of work. I think we would never have been able to kind of move this along if it wasn't that, without that system-wide approach, navigating through all these pathology trusts, clinical pathways. It's really quite an onerous task. So well done, and thank you for all, the results you've presented. I was just literally going to provide one slide with a few of my thoughts on the benefits and the lessons learned from IMPACT from a clinical perspective. As an oncologist, we really see the results of getting molecular results to us in a really timely fashion. This is where the patients are going to see the benefit. And in the time of this project, I have noticed massive improvements in the speed in which we're getting the molecular results. Then now I treat gynae cancers, so for endometrial cancers, we're seeing that molecular results at the time of MDT discussion, which enables us to make the correct and timely decisions for our patients. And that's, the driver for this type of project. I think in a wider setting, understanding the details at the granular level that Jenny mentioned really is very important. It might seem that we're perhaps getting too much data. Was it really worth it? But I think having that detail from the outset has really allowed us to understand the system, and also not waiting for the results, seeing those identifiable improvements along the pathway and making those changes. Some seemingly small changes have led to real benefit. So yeah, I think the time and effort going into it has really yielded excellent results. I think the other thing is that we've really fostered great relationships that didn't exist prior to this. When we first started entering in the world of genomics, everyone was working in slightly different ways. We didn't really communicate. And this type of project has brought together all those specialties to communicate and really try and drive this type of system improvement. We have regular meetings across the the alliances, and with the GMSA we keep in touch, and we really have those communications ongoing. And as I say, I think the big thing is you can't do this on your own, and having the alliance and the GMSA behind you to really drive these system-wide changes has been crucial in this. As we've had 6 pathology labs to deal with, multiple trusts, and those improvements have really been enabled by working together with the Alliance and the GMSA to drive forward those improvements. Hopefully, we'll be able to widen this out into other tumour types. Some of the lessons learned will be generic, I guess, and the education that we will adopt from this project will have wider benefits to other tumour types as well and to the system. So, I think we've gained a wealth of information and improvement from this project, and I say it's made tangible benefits for the clinicians and the patients as well.
Great, thank you, Rosie. And I think that's us done, apart from to say, are there any questions, comments or queries from colleagues here, either in the chat or if you want to jump on the screen? So I'll just open it to the floor for any questions. I feel we may have dazzled everybody with science, which is entirely appropriate. Okay, it looks like there's no questions, comments, in which case, thank you everybody for attending. Like I said, it's been recorded, we'll be hosting it on our Cancer Academy. The invite came directly from me, so hopefully everybody has got my email address. If there are any follow-up questions or anything people wanted to follow up with us, we're very, very happy to share any of the detail and methodology of this work. Happy to help support colleagues if they want to look at how they might enter into this. Specifically, as Stuart mentioned in his presentation with the GSIB work that the GMSAs have now started, I think there's definitely more and more collaboration that we can pull together as GMSAs and cancer alliances. So thank you for the kind comments in the chat. I think we'll leave it up there and we'll head for an early brew. Thanks again to the presenters, and hopefully we'll hear from you soon. Thanks very much.
Thanks a lot. Bye-bye.
Thanks, everybody.